Know Your Calling family. Today we have Dr. Apoorva Zarkar with us for the interview. She hails from Pune. She has completed her MBBS from Government Medical College, Maharashtra. And while she was doing her internship in BJ College, Pune, she got through NEET and chose to do the 6-year DNB course in Sangli. And now she's pursuing her pediatric surgery course. Now she's in the 5th year of her residency. We are so happy that you are spending so much time for us, ma'am. And we're inviting you to this platform.
Thank you so much.
Good evening, ma'am. How is your day?
And like the routine day in residency as usual.
Was it very difficult, ma'am? Is it hectic in pediatric surgery?
No, like, see, the thing is that basically I'll just introduce my branch. It's
Sure.
pediatric surgery. Actually, many people like they have a wrong conception about pediatric surgery. Half of them think pediatric surgery is basically general surgery in small children. Okay. First of all, that's a very wrong concept because pediatric surgery is totally different from general surgery. Whereas general surgery includes the routine cases like hernias, hydrocele, abdominal surgeries, traumas. Okay. Pediatric surgery, basically, more than half of pediatric surgery are congenital cases, which we need to treat, and that too at birth. So, like more than 50% of our patients are 1 or 2 days old babies, and which cannot be handled by a general surgeon. So, it's a very wrong conception. Key pediatric surgery is just a miniature version of general surgery. So, first of all, it's totally different. And secondly, people usually believe uh, many of them who do not like pediatrics, even they do not think about taking pediatric surgery, thinking that we'll have to treat pediatric patients. So even pediatrics is a totally different branch because pediatrics includes all the medical basis of treating children, whereas pediatric surgery, although in critical cases you do require a pediatrician for help, and intensivists especially and NICU babies, but pediatric surgeons do not need to look at the pediatric part of that patient,
Okay.
like the doses and all. The basics of pediatrics, it's fine, we should know. But a person not liking pediatrics should not opt for pediatric surgery. That is not an option.
Okay, ma'am. So you're saying it's very different. It's not from pediatrics, it's very different.
Yeah.
Okay, ma'am. Ma'am, can you tell me how your day was and how your week goes? In general, how is your schedule?
Yeah. So actually, I am doing this 6 years direct pediatric surgery after MBBS. Uh, 6 years pediatric surgery, like during our MS residency or during the MCH period, 3 years of residency usually goes on like the first year residents have the maximum amount of workload. Then it divides among the second year people, and the third years are usually exam going, and therefore they're like the last 6 months are usually light compared to the first 2 years. But here, at least in our institute, the 6 years course, the pattern of work is very different. Actually, from the first year, starting from the first year to the last year, we are JR1s itself. So it's like because uh, like people like the seniors are getting passed out, but then the workload stays the same. So
Okay.
basically, we don't have a proper unit system here, but like we are on call on one day and off call on the other day. So on call, like it starts at 7 in the morning, and
Okay.
then we need to take the ward rounds, the NICU rounds, the SICU rounds. After that, it starts with the OT usually starts at 8:30 in the morning. So there's a pretty much of workload at our institute because since like this is an DNB institute, but then we have all the government schemes. So then the workload is pretty much like daily on a routine basis. We operate around 10 to 15 cases daily.
Oh,
So we have like two OTs, and then the OT starts at 8:30. So the cases, like majority of the cases, get over by 1. Then after 1, we our OPD starts. So OPD goes on till 4. Any emergencies between that are done, like from 2 to 5. The second session of the OT goes on. Then At 5, our second round of OPD starts, and it gets over by 7, around 7. And after that, like the admissions, like around there are 10 to 12 admissions daily. So the pre-ops, the any investigations, any like the blood orders, whatever, all that goes on till 9 or 10 at night. And then like each group, we are divided in two groups. So say suppose we are three people in one group. So every person would have a night, like alternate night. We'll have an alternate night. So like after 9, if all the work is done, now it's my night today. So then the night calls or the admissions coming at night, I need to admit all of them. And the night goes on till the next day in the morning. And next day at 8, I need to be in the OT. That's the off call day. So OT will go on till 5, and after 5, I'm free next day. That's
Okay. Ma'am, and do you get free time for yourself and family? Like Sundays, are
uh,
you working on Sundays?
yeah. It's like actually, since we are divided in two groups, one Sunday is an on call and the next Sunday is an off call. So we basically get 2 Sundays free in a month. So
Okay.
that are the only holidays. Like nothing, and that too if somebody's like on a leave, or if some seniors have their exams, or if there's an emergency case, we need to attend those Sundays too.
Okay. 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 Thank you, ma'am. So you have told us about your branch and how the schedule is. Now, can you tell
Yeah.
me what you enjoy the most about being in this branch?
See, basic, although any surgical branch is usually very hectic, okay, because it goes on with like the pre-operative investigations are a lot, followed by if the patient is already serious, you need to first manage the patient medically and then go on with the surgical part. But surgery is not the only thing. Post-op, you have many things to watch over, right? So uh, actually the entire day goes hectic, but basically we are always in touch with these small babies. So actually, which is very cute. And personally, like while choosing this branch, I always wanted to take surgery as a branch, but like looking at the 6 years, I found this a good option because like um, after MBBS, doing MS for 3 years, then you have a 1 or 2 years bond for MS after MS, especially in Maharashtra. After that, you do MCH for 3 years. After MCH, you have a compulsory 2 years bond.
Oh,
So by the time you become a pediatric surgeon, I would have almost spent 10 to 12 years and also 1 year of an MBBS bond. So directly taking the 6 years course was like uh, the we don't need to do any bond. Like there's no bond in DNB. Plus, pediatric surgery, since I'm going to do later, like the entire life, I'm going to do pediatric surgery. It includes basic cases of general surgery. So it's not like I'm missing a big part of MS. Like, you know,
so there
like
is
for
covering up for it also.
yeah, it's covering most of the parts of general surgery. And that too in 6 years, we usually we have two exams in 6 years. The first part usually happens after 1.5 years, which has general surgery as the syllabus.
Okay.
So in that we anyways have to study general surgery, plus we have a 1 year of posting in general surgery.
Okay.
We learn basics of general surgery. And talking about pediatric surgery, usually, like I told you previously, pediatrics includes sick babies, I should say. Pediatric surgery, the babies don't apparently look sick. Like they have these congenital anomalies, but they're thriving well over that. So
Oh,
they don't have this sick look or very preterm look. Obviously, if there are septic babies, like these babies with necrotizing enterocolitis or children with empymas, barring that, the routine patients which we have, they apparently look healthy. So
oh,
we enjoy this environment with active babies. So that's the
oh.
best part of this match.
Okay, ma'am. So we thought it would be a scary sight, pediatric surgery. The babies will be so sick, but you have busted that myth for us. Thank you, ma'am. Ma'am, can you tell us the disadvantages of being in this branch?
Mm. See, every branch is going to have its advantages and disadvantages. Like I don't know how to talk about disadvantages. Like someone who does not like this branch is a disadvantage for that person.
Mm.
Like what I mean to say, every time while choosing a PG branch, you should first be clear with what do you want to do in life. Like you cannot point out specific disadvantages because since, see, now I'm in my fifth year, but still I'm learning newer things. So we should not, call it as a disadvantage. Like if you keep on like grudging about your branch from the start itself, then it's going to be very difficult when you go ahead.
Okay.
Like anyone choosing a branch, I just want to say ki first you decide within your mind whether you want a surgical branch or a medical branch.
Mm.
That's the basic differentiation. What people usually do is initially they have a liking for a different type of branch, and during MBBS, then during internship they think of something else, and then during PG, based on the ranks, they try and choose a branch, which is very wrong. Like I have had friends who were very keen on taking pediatrics, then general surgery, but then later there were two friends who got a very good rank. They just opted for radiology just because they were getting it at their rank. There were two friends who were getting surgery and all, but they were like, then these branches are very hectic. Why to choose them? Then just let's take a lighter branch. Don't choose it based on your rank.
Okay.
Choose it based on your liking. Because if you choose it based on your rank, then you'll just like go through those 3 years the way it is, and later you'll repent all your life. So,
Ma'am, what kind of personality do you think we should have to take pediatric surgeon?
uh, not specifically like basically you should like surgery, and you should understand that surgery includes long amount of standing, like the entire day of OTs. Like you need a lot of stamina just to like the OTs go
Get
on
through the
the
day.
OT, throughout the day. Actually, in pediatric surgery, the OTs, like a single OT does not go on for that long,
Oh,
because babies are small. We can operate faster in babies, and even in small babies, like I told you, we operate on 1 and 2 days old babies, so we cannot like increase the amount of anesthesia time. Even that causes a risk to their lives. So we
mm.
need to do faster surgeries, like as fast as possible.
Okay, ma'am. Ma'am, is it scary that you're operating on such small babies?
No, 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 nothing
Mentally,
like
it is
that.
exhausting.
See, initially, obviously, when I joined this branch, the first 2 months, I did not even touch neonates, and in the first 2 3 months, we are not even allowed in the NICUs because we are not used to small babies. And looking at pediatric surgery, we don't have as a posting during internship, right? Pediatrics is what we have. So in that case, we're just used to seeing small babies, but we don't usually actually handle them. And just even putting gelcos and all to small babies during internship, we learn putting adult gelcos. Babies are out of question. That too, preterm small babies, they are out of question. But then the only thing, once you uh, like start conversing with small children and all, you get used to it,
Okay.
and you just need to have the art of holding smaller babies. Like that's not a big deal. Like every person learns everything during the first year of residency. That is what it is.
Okay, ma'am.
There's
So,
nothing different in that.
you're telling the people who are interested in it that it's a skill we will learn over time.
Yeah, yeah, nothing scary in that. Because see,
Okay.
once a baby is anesthetized, it does not depend how big or small the patient on table is. You have to operate.
Okay.
So that the only thing is pediatric patients, they're very small, tiny babies. Like in general surgery, the forceps, like the length of the forceps and the length of our baby's abdomen is the same size. So we have smaller instruments. They're not even as miniature as the forceps used in optam and all, but they're very small instruments, which are not usually, like, we don't use the general surgery instruments. We have special forceps, special needle holders, special scissors, and like if you say majority, like more than 50% of pediatric surgery includes these GI cases, like pediatric gastrointestinal, like intestinal atrasias, any malrotations, volvulus. So in such cases, when we open the abdomen of the baby, the intestine is so small, like it's smaller than a little finger, and we need
Mm.
to do anastomosis in such small cases, in such small spaces. So that is the art and challenge of pediatric surgery, but then that will like get up over a period of time.
Okay, ma'am. Ma'am, so are these patients like do they follow up with us or do they go to the pediatrician? Are they our patients or do you get patients by reference?
No, like see, around 50% patients come at reference, as in like half of the patients they come, like the ones diagnosed antenatally. Like our patients usually start even with the when the parents are known of any anomaly during the antenatal scan. So our
Okay.
patients basically start from there itself. Like
Okay.
around 20-30% are these antenatal scans who come to us with like these PUJ obstructions or a bladder outlet obstruction. So they come for consultation. Actually, if they come very early, like patients usually come after the fifth or sixth month. So
Okay.
basically, that is the time after 6 month you cannot go for any abortion or anything. So it's just like, will you save my baby after the baby is born? That is
Okay.
their main question, and it's like whether it's a very major anomaly or can it be handled. So these are 20% of the patients. Around 50% of the patients they're referred like after an LSCS or a normal delivery. There's when there's an absence of anus, the baby's not swallowing, there's an esophageal atresia, or babies who are already diagnosed antenatally with some renal anomaly or some intestinal anomaly, or
Okay.
babies like after birth who are not like who start vomiting, like bilious vomiting after feeds, they are directly referred to us either by the gynecologist or the pediatrician.
Okay.
And
S-
these older kids like patients with hernias or any appendicitis, they come directly.
okay. So,
Yeah.
ma'am, how is the life of a resident and a consultant different in pediatric surgery? Is it like which is lighter? Will it keep on getting hectic, or how is it?
No, I like see. Presently, I'm still doing my residency, so I don't know afterwards how it's going to become. But the thing is that see, during residency, it's like whenever even if you have your nights, although there are no admissions, but there are these NICU babies. Some are on ventilators, some are like just critical. So in babies, like usually in adults, how it goes on, ki whenever we give instructions to our staff, the hospital staff, it's like. These many points of IV should go over the night or whatever. In pediatrics and in pediatric surgery, it's basically like ml wise. Like for small babies, it should go like 12 ml per hour. There should be exact IV values. Or if some baby gets critical, like the convulsions and all, post-op convulsions, not usually attended by the staff. This is what we need to go through.
Okay.
So during residency, it's like the entire night goes on keeping a monitoring every patient.
Okay.
When you become a consultant, it's like if you teach your staff and your juniors the basic stuff, you can just come at the crucial time, like during surgery or just pre-op, just a visit. Once
Okay.
you've taught everyone everything, it's not like gynecology, like OBGY. I don't know how it is, but what in general we hear is as soon as the patient comes, your nights are spoiled, everything is spoiled. So not in that. There are only certain emergencies in pediatric surgery, like if there's a torsion of the testes or the ovaries, or there's a foreign body ingestion, which goes directly into the bronchus. If the saturation is dropping, only those are the emergencies where you need to operate immediately at night,
Okay.
but not otherwise. Even
Okay.
if a perforated appendix, you operate like in the morning, the next day, because it's already perforated. You can wait for 4 hours. You don't need to spoil your night for that. Yeah.
Okay. Okay. Okay, ma'am. So the amount of emergencies is low in pediatric surgery.
Yeah, like if you teach the on-call person whatever it is, then it's quite better. Like the entire life after consultancy is not going to go and just go and attend patients. If you teach the basics to your juniors, then you can have a good sleep.
Okay, ma'am. So is there any gender bias in the branch?
Nothing that ways. Like I don't know actually. There's no gender bias in pediatric surgery. Like basically, I even chose this branch because the other surgical branches, like urology or GI surgeries, mostly, especially urology, they mainly prefer the male surgeons. But that's
Oh,
not the case in cases of pediatric surgery. Pediatric surgery, male, females, both can do it.
okay.
It just
Ma'am.
depends on the skill.
Okay. Thank you. Ma'am, what about the settlement time, like the salary and all that?
Mm, See, people say ki like they have a misconception कि pediatric patients will give you less than 50% of the income because they are pediatric. In fact, nothing of that like happens usually. See, after you um, like after your residency, initially you anyways join as an SR or a lecturer or an AP in any institute. So that salary stays the same in any branch. Later, while working, as you previously said, like you should have more of these pediatrics and gynac friends, like who will refer patients to you. But in any case, it's not like you'll get low payment, because the thing is that since pediatrics involves a skill, a normal surgeon is not going to easily operate on a 1 or 2 day baby who's 1.2 to 2 kgs. That will be only done by a pediatric surgeon. And looking at the present scenario, there's a lot of scarcity of pediatric surgeons, basically due to this like wrong conceptions about pediatric surgery, like as I previously mentioned. So that's the reason people, I guess, they're not trying to take this branch. And thinking monetary wise, there was one more thing people were thinking ki, as like this radiology is flourishing and the modes of these investigations, like there are ample amount of investigations done antenatally. So what people usually think is these antenatal anomalies, they're going to go off. Therefore,
Mm.
pediatric surgery will not have a future. But that's very wrong.
Okay.
Presently, what is happening is usually, as you know, especially among doctors and even others, like these days, marriages are late.
Mm.
There's a lot of pesticides and everything. So the amount of congenital anomalies, in fact, is going on increasing.
Okay.
You only understand when you come across someone like that. Till that time, you always feel your baby is normal.
Mm.
But then once your baby gets that, and although radiology is highly advanced, not every anomaly is going to get detected antenatal. Still 50% stay the same. And when we've spoken to many radiologists, like many times, even the obvious anomalies are missed. But it's not like it's missed only among the poor people. Even the well-to-do people going to very well-known radiologists, many of the anomalies they can be missed. We've spoken with radiologists why usually it happens with the ones which could be easily detected antenatally. What they meant to say is at times the position of the baby is different, or at times that part of the bowel is not distended, so it's not visible enough.
Okay.
And also there's loss to follow up. It's like in among poor people, what happens is this pregnancy and delivery that costs a lot, so
Mm.
they're not going to spend on basic stuff. And
Mm.
after birth, it's a big shock to them. And the thing is that babies presenting to us with the absence of anus, absence of an esophagus, if we do not operate at that point of time, they're not going to live.
Okay.
So they have to be operated. Like they don't, the parents don't have an option. We'll see after 4 years, after 5 years. That's not an option.
Okay.
What matters the most is counseling in pediatric surgery, because no parent is going to let you operate on your baby immediately after birth. Like the parents are like, the baby's so small, how are you going to operate on our baby? But they don't understand we are the ones who are going to do these surgeries. What they feel is why are you operating and what's the need for surgery. So explanation and counseling is a very important part of pediatric surgery.
Okay. Ma'am, what about the scope for subspecialty?
See, actually, pediatric surgery itself is a it's like a vast branch. Like it includes head to toe almost everything. Like even some part of neurosurgery, like we do surgeries for hydrocephalus. Starting from the brain, we do surgeries for hydrocephalus, and in neuro, we also do surgeries for these like meningomyelocele, etc. Hello.
Yes, ma'am. I'm here. I'm here.
Then see, barring intracranial surgeries and the heart, everything is a part of pediatric surgery. So pediatric surgery is very vast, starting from the as I said, the hydrocephalus, then the esophageal anomalies, then the lung infections, lung anomalies, tracheoesophageal fistulas, then in the intestine, the intestinal obstructions, urology, and even the external genitalia, like these ambiguous genitalia is operated by a pediatric surgeon, then hypospadias surgeries. Like you might not know all of this, but I'm telling it's a vast branch. So it's like there are fellowships in pediatric surgery, like pediatric urology, pediatric robotics. But then it depends. After doing pediatric surgery, Fellowship depends on you. Like you can even do a fellowship in minimal access surgery. But within pediatric surgery, you can choose what do you want to operate.
Okay.
And pediatric surgery does have clashes with many of the other branches, like I said, in neurosurgery. Also, in cases of like these hypospedia surgeries and these cleft lip, cleft palate surgeries, they are also done by plastic surgeons.
Yeah.
Yeah. So then these are like intervening things. But then it depends on the pediatric surgeon what he want to specialize in. In general, you can operate any of the thing, barring the heart. But then if you want to specialize just in pediatric urology, you can do those sort of cases. So you have fellowships in those specific specialities, subspecialties.
Okay, ma'am. Ma'am, is this a branch that supports research? If you're interested in research, this is a good branch for you.
Yeah, obviously. And see, many aspects of pediatric surgery are yet to be come into picture, because basically this fetal surgery is like when the baby's within the womb, you operate even on those cases. So that's not yet into good practice, at least in India. It's there in foreign countries, but then that's a very interesting specialty where I would like to go ahead later.
Oh, okay, ma'am.
Like the thing is that like when there's like I'll just give you an example. Like
Sure.
when there's any obstruction to the bladder. Okay, so there's retrograde high pressure changes over both the kidneys, right? Until the baby is born, already 9 months have elapsed.
Mm.
And then when you try to treat the baby, although how much ever you treat the baby, the kidneys are going to suffer. Since at least 7 to 8 months, they were under high pressure within the womb. So fetal surgery is such a branch कि antenatally using scopes we can temporarily relieve the outlet obstruction, bladder outlet obstruction. So at least the
Okay.
kidneys are safe. And then you do the permanent, what do you say, like permanent treatment after the baby is born. So at least you
Okay.
do something palliative
No,
antenatally.
such innovative things are coming up, and research has a
Yes.
good scope.
Yes.
Okay, ma'am. Ma'am, is there a special story you would like to share about like something related to the branch? What motivated you or inspired you, or a good example?
Mm. Like motivated me to take the branch, or like what is going on
The
within
branch,
this?
like within either anything related to the branch.
No, like nothing that ways, but like we feel like honored or we feel pleasured when actually when we get such delicate neonates. um our basic counseling always involves ki although we operate and the surgery is 100% necessary, we cannot give you an entire guarantee of the baby. Like that happens in every single branch, but in pediatric surgery it's specifically said because not only the surgery is what matters, also the weight of the baby, the general condition of the baby is what matters. And like once after 5 days post-op, the babies are discharged home. So like that's a very good thing. Like the relatives, like usually the relatives, they're very happy usually because once
Okay.
they've already thought of ki, handling such small babies. So that ways, like nothing specific. Every day there's a different story. Like I
Okay,
cannot
ma'am.
recall any single story.
Okay, okay. Ma'am, how about while choosing colleges? Uh, which colleges provide better hands-on experience, or what should we look for when we are choosing colleges to do pediatric surgery?
See, basically for pediatric surgery, uh, um, during these 6 years of residency, it's not that you're going to get everything from the first year itself. Like the distribution of cases goes year wise. So the first and second years you'll just get the basic surgeries like circumcisions, hernias, undescended testes, and in the third and fourth year you'll start getting like small laparotomies and all. And the major cases you'll get after the fifth or sixth year. So in DNB especially, what usually happens is DNB institutes are basically like the seats in private hospitals, right? Like
Yeah.
government seats in private hospitals. So in such cases, it happens to be ki, people feel you're not. like when you choose a big institute, a big corporate hospital, usually the hands-on are very less in corporate hospitals because you usually have VIP, VVIP patients there. So
Okay.
choose a DNB institute where there's a lot of workload and it's not a very hi-fi, high-to-do hospital, so that you get hands-on in that institute, specific institute.
Okay. Okay. Thank you, ma'am. Ma'am, do you have any warnings regarding the branch? Something
Yeah,
you would
morning.
like to?
Um, like being a surgical branch, first of all, there are many people like, who faint even on seeing blood and all. But then all that you should understand during internship itself, ki whether you can handle or whether you can see a surgery properly. Like you don't have any phobia for blood and anything. One is just to choose between a surgical or a medical branch. And one surgery, just see ki you don't have this total hatred for babies. Yeah, and one more thing is that a pediatric surgeon, like a pediatrician, they learn to sleep. Like, the babies are crying the entire night.
Oh,
So you're not going to have a peaceful sleep at your night. It's not going to be, you cannot, you just shut the mouth of babies and say, don't cry or anything like that. And secondly, it's like you need to be a very good observant. Your vision should be very good because babies are not going to come and tell you that my stomach is paining or I'm becoming septic or I have a distension. This is all what you need to learn through working.
okay. Ma'am, we have heard that the moment we entered our pediatrics posting, the first thing the consultant said is pediatrics is the advanced annual science. So there's nothing. At, she said it's advanced annual science, wherein
Okay.
the children has no problem, but the
Huh.
mothers say they have this problem, that problem, and you have to go find and observe. I'm
Right.
so glad that you reinforced that point.
Yeah. Sure.
Ma'am, are there any other special messages you would like to tell us as students? Maybe if you want to take pediatric surgery, do this, or like maybe watch surgeries. Any recommendations like that?
Mm, no, like not that ways. But while choosing a branch, like what we have routinely observed, even after MS, people who are choosing MCH pediatric surgery, like more than I guess more than 50% of the MCH seats of pediatric surgery go vacant. Basically, the main thing for this is ki, like for the like during this NEET SS, the rules might they are going to change this year, I guess. But the rules were to choose just two branches. So, having these wrong conceptions of pediatric surgery, first of all, no one goes and chooses pediatric surgery. Everybody's just behind uro and gastrointestinal surgery. But then once only the toppers get that branch, then you're left with nothing. Then you
Mm,
just have an option, go and repeat. So don't do that. Even look at other branches is what I want to say. And secondly, pediatric surgery, there's a lot of scarcity of pediatric surgeons, and it's not going to wane off this branch. Because as I told you, the anomalies, since we are going through so much and there's so much radiation, there's so much everything to do. Even the age of marriage is increasing, the age of pregnancy is going on increasing. Although you have very good radiological support, some of the anomaly goes undetected. And
mm.
it's not like the workload for pediatric surgeons is going to stop. People were usually like pediatric surgery, I guess it started in 1970. So at that point of time, people were like, in the next 30 years, this branch will go off.
Oh,
Because initially there were no investigations antenatally, and now it's so advanced so that you don't need a pediatric surgeon, but that's not the case. And as I told you, 50% are congenital anomalies. The other 50% are babies after birth, right? It also includes pediatric oncology. Who's going to treat that? A general surgeon cannot open a small abdomen. A 6 months baby's abdomen cannot be opened by a general surgeon. I'm sorry.
oh, okay, sir. Um, Ma'am, thank you for your time. Is there anything else you would like to tell us before we wrap up?
No, nothing. What I just want to say, I just want to say it's a very good initiative from your side. Here, you people have come up with this idea because even I remember during choosing my residency, it was very difficult. And I just want to say is don't run behind the branch. Run behind your choice, your personal choice, and that
Okay.
should be in your mind at least during the third or fourth year of the MBBS, you should start liking some of the other branch. And I am sure, like, theoretically reading a subject is different, and the one thing you attend during internship is totally different. But during internship, you at least get around a small amount of idea of every subject, so you can choose accordingly. The only thing I would like to request every person is ki run behind the branch, or don't run behind the rank, or don't run behind what the society says ki matlab itna rank aaya hai, so you have to take this. How you're taking this? Why not? Like 1 or 2 years back, there were even incidences. The person with rank 500 or something, even he had chosen this physiology. One person with rank 2000 or something had chosen anatomy. So it depends on personal choice. I'm not saying go for a non-clinical branch. First is you choose between clinical or non-clinical. Secondly, once when you're choosing a clinical branch, you should be 100% sure in your mind whether you want a surgical branch or a medical branch, and only then go ahead.
Okay.
Like there are many queries even on Facebook and on all the other DAMS groups and all, like whether I should choose between psychiatry or orthopedics, whether I should choose between medicine or essay. So how you cannot choose contrasting branches.
Okay.
And any branch you want to choose, I want to say ki before you like fill the options, you should personally at least go in the nearby college near you and talk to one of the residents there
Okay.
to get an idea of that specific branch.
Okay. Ma'am, just one last thing. How much do you think AI, like artificial intelligence or interventional surgeons can take over pediatric surgery?
No, AI as in AI is like coming as a part of pediatric surgery, and especially where these Da Vinci robots and all, when
Mm.
when their role comes, so they in those cases, like where when we are going to advanced laparoscopic or where we are going to advanced robotics, in that AI plays a role.
Okay.
So it's not directly pediatric surgery. It's like how the instrumentation is going to change over. That will be of a better help to us.
Okay.
That way it's going to work. Yeah.
Ma'am, what about interventional surgeons?
No. Surgery is interventional. Like,
Okay.
what? See, it's a general question. Like, it's would be a general question of your part. But then, see, like radiologists, we call them interventional radiologists, right? So
Yes.
that way you're asking. Surgery
Yeah.
is an interventional branch. Radiology is like diagnosis. You put a probe over the abdomen, and the USG is done. But that you use an USG guided. You do an aspiration, so that is an intervention.
Okay.
Like you're invading the body. Surgery is intervention. So there is
Okay.
no, yeah.
Okay. My bad, ma'am. So thank you so much for spending your valuable time with us, ma'am. We are so glad that we got to study so much about pediatric surgery, and we will keep in mind the points you told us about observation and the attitude we should have towards the branch and things like that. Okay. Thank you for enlightening us, ma'am. Shall we wrap it up here?
Yeah, sure.
Thank you so
Thank you
much.
so much.